get marital counseling prior to marriage?
Got everybody? Bolton's here. What time is it?
I'm here. 8 o'clock.
Okay. Couple of announcements first for the residents who may not be aware. As of Monday, if things go well, we will have a new interim chairman. We have a retired MFM by the name of Hessline, who is coming from University of California at Davis, as well as, what's the other one that's out there? Not
He's at Sacramento.
He's in Sacramento. He will be our interim chairman for the duration. We do not know what length of time we're talking about. That will basically allow both Dr. Holmes and myself to avoid meetings, avoiding signing stuff, and being able to do other activities that we think are equally important. So he'll be around starting Monday, but I suspect the first couple of weeks will be just orientation. We have budget hearings coming up, so I think that'll be his first involvement with the department. I'll sit down and go over our schedules with him, explaining to him what's going on. And if there are other things that we need to point out, I will be more than happy to do that. And ask me what's going on, because I have a better understanding of where we stand with all of this. Today, we're going to have a unique lecture by Dr. Meredith Bolton. Dr. Bolton is a East Tennessee young lady. Dr. Bolton comes to us out of East Tennessee State University, but she's been in Upper East Tennessee, as I like to call it, all of her life. She is now moving upward in terms of taking over some of the leadership aspects. And today, while she is going to talk on transgender patients, I'm unfortunate. I did look for transgender questions in every prologue that I have, and according to ACOG right now, it's not that important because there were no real questions on it. So we're learning brand new information from Dr. Bolton.
Thank you, Dr. Jernigan. So talking about transgender patients today, the reason for this topic is because on our CREOGS this year, which is the test that all OBGYN residents take every year across the country, our in-service exam, we had several questions on treating transgender patients, hormone therapies, risks in terms of treating them with hormones, and the consensus of the residents was, I don't know. So I decided we could do this for a topic, and that might increase our knowledge of the area. I have nothing to disclose. No one that I know of is paying me to be here in terms of giving this particular speech. So just some examples of transgender individuals in our entertainment industry today. There's Chaz Bono on the left there, who is the son of Sonny and Cher, born a female. And then Laverne Cox, who's from the popular Netflix series Orange is the New Black, who plays a transgender female in the show, but is also a transgender female in real life. And then on the bottom there, Jared Leto from the movie The Dallas Buyers Club, which is about the AIDS epidemic, and he plays a transgender female with HIV. So just some overall general definitions, a lot of different words: transgender, transsexual, gender identity, what all does it mean? So essentially, gender identity is just a person's own sense of feeling female or male, and actually both or neither. The birth sex is the sex that was assigned to the individual at birth just based on their external genitalia. And transgender is a person, in essence, whose gender identity is different from their assigned sex. Not necessarily they're male, but they feel female, or female and they feel male. It can also be, again, that both or neither category. So not just strict boxes of labeling people. A trans male or a transgender male is a person born with female genitalia but feels that she's a man. And then a trans female or transgender female is a person born with male genitalia but feels he is a woman. A transsexual is actually a subgroup of the transgender, and they're actually people who have transitioned to their expressed or desired gender via either cross-sex hormone therapy with or without a sexual reassignment surgery. Sexual orientation is just, in essence, the attraction of a person to others, so not related to their own gender identity. So transgender people can be straight, homosexual, neither, bisexual. It doesn't matter in terms of themselves being transgender. People who have gender nonconformity is essentially how much they conform to what society says that that person's sex should do, feel, how they should dress. And then gender dysphoria is the psychiatric diagnosis, and essentially is the distress that the incongruence of feeling to be another gender has on that person that is different from their assigned gender. So some numbers. Only 0.3% of the U.S. population are transgender, so that's a really low number, although it's becoming a bigger area of discussion and getting more attention, and they think that that's actually much on the lower side of what it actually is, just based on, you know, social stigma surrounding these individuals and fear of, you know, coming out and being themselves. 60 to 70% of transgender people have used cross-sex hormone therapy. Only 20 to 40% of transgender people have actually undergone some type of reassignment surgery. These individuals are more likely to be homeless, unemployed, and low income. They have higher rates of alcohol and drug use, and they are more likely to engage in sex work and thus have an increased risk of sexually transmitted infections and also being victims of sexual assault and violence. So, just a little bit of history. People have actually found that even going back to ancient history, there have been examples of what we would think of as being transgender or cross-dressing throughout history. Cybele, to the ancient Greeks, or the Great Mother to the ancient Romans, was an intersex deity in whom the two sexes had not yet split. Mukhanathan in ancient Islam are men who resemble women, which is mentioned in the Hadith, which is a body of reports of the teachings, sayings, and deeds of the Prophet Muhammad. Sardanapalus was the legendary king of Assyria, essentially representing a mix of three of the Syrian rulers, who was thought to dress in women's clothing and emulated mannerisms and voice. And then in Japan, you have the Wanagu Nati, which is the shaman ritual of becoming a woman, where male shamans become female shamans, or the yuka. The first one is a famous French spy in the 1700s, who actually was known to dress as a woman, and actually, upon his death, no one actually knew whether or not he was really a woman or a man, and at that time they confirmed he actually was a male. Karl Heinrich Ulrichs in 1864 was a German lawyer and pioneer of gay rights, describing gay men as having a female psyche caught in a man's body. Himself as a child wore female clothing and liked to be known to wanting to be a female. And then Magnus Hirschfeld was another German physician and sexologist. They called him the Einstein of sex, and he actually coined the term transsexualism and transvestite in 1923. This lady right here, Christine Jorgensen, was actually an American male-to-female transsexual who brought a lot of national attention to being transgender in 1952 based on her reassignment surgery. And in the 1950s, John Money of Johns Hopkins made the distinction between gender roles and gender identity. And then Harry Benjamin there was an endocrinologist whose work in the 50s and 60s on transsexualism helped make it become a psychiatric diagnosis. So the DSM is the Psychiatric Diagnostic and Statistical Manual of Mental Disorders. So transsexualism first appeared in the DSM-3 in 1980 and was part of the psychosexual disorders. In the DSM-3R in 1987, transsexualism was grouped in the gender identity disorders first evident in childhood or adolescence. Then in the DSM-4 in 1994, they actually had the term gender identity disorder as its own entity. And then the DSM-4-TR in 2000, it was grouped with the sexual dysfunction and paraphilias. And the most recent version of the DSM-5, they changed gender identity disorder to gender dysphoria because they wanted the emphasis to be more on the dysphoria than on the actual identity as causing the diagnosis. So a little bit more about gender dysphoria. This lady here is a trans female who actually made news because she was in the Miss Universe Canada pageant and was actually disqualified because she was transgender. And I think she was later reinstated, but I don't think she won. But she brought a lot of worldwide attention to that. So in the DSM-5, gender dysphoria replaces the term gender identity disorder because of the focus, again, on the dysphoria as a clinical problem and not the identity itself. There are different diagnostic criteria for children, and then it groups diagnostic criteria for adolescents and adults together. There must be evidence of a distress caused by the incongruence in order to be able to diagnose these individuals with gender dysphoria. And just of note that being transgender does not mean that you have the gender dysphoria diagnosis. So children, this is a lot of information. So essentially you have to have in children a marked incongruence between the gender that they want to be and the gender that they've been assigned for at least 6 months. And they have to have 6 or more of these criteria, of which number 1 has to be included. So they have to have that strong desire, which is different from their assigned gender. In boys, strong preference for cross-dressing or simulating female attire. Girls, strong preference for wearing male clothing. They have to have a preference for opposite gender roles whenever they're doing their make-believe or fantasy play. And a strong preference for the toys and games typically preferred by the other gender. They have to have a strong preference for playmates of the opposite gender or other gender. And boys, typically, strong rejection of typically masculine toys, games, etc. And girls have the strong rejection of anything feminine. They have a strong dislike of one's sexual anatomy and a strong desire for primary and or secondary sex characteristics that match the gender that they want to be. The condition is associated with clinically significant distress or impairment in social, school, or other important areas of functioning. And they also specify in the DSM-5 if this is occurring with a disorder of sexual development like congenital adrenal hyperplasia or something where you have more the ambiguous genitalia. So in children, they've actually seen in children who have been referred to gender clinics as young as 2 years old having gender dysphoria. However, the persistent rates from childhood into adolescence and adulthood in males 6 to 23%, females 12 to 27%. So just because a child is diagnosed with gender dysphoria does not necessarily mean as an adult they will be a transgender individual. They have to have a preoccupation with cross-gender wishes, which often interferes with their daily activities, which can lead to isolation from peers, refusing to go to school, behavior problems, basing from harassment or pressure to dress and their assigned gender. And the male to female ratio in children is ranging from 3:1 to 6:1, so you see it more often in males. Common comorbidities with this disorder or with this diagnosis, emotional behavior problems, anxiety, impulse control issues, depression, and some studies that I read show that there's a prevalence of autism spectrum disorders in children with gender dysphoria. Moving on to adolescents and adults. So again, that marked incongruence has to be there for at least 6 months. They don't have to have as many criteria as in children, only 2 or more. again, that marked incongruence between their expressed or desired gender and their primary or secondary sexual characteristics. A strong desire to be rid of their sex characteristics because they feel that they are not that sex. And then a strong desire to have the opposite or the other gender that they desire, their secondary sexual characteristics. And then again, a strong desire to be the other gender. A strong desire to be treated as the other gender, and then a strong conviction that they do possess the feelings or reactions of the gender that they desire. Again, the condition associated with clinically significant distress or impairment, and they also specify if it occurs with a disorder of sexual development, and they also specify in the DSM-5 if they are post-transition, so that means that the individual is living full-time in their desired gender and has undergone or is preparing to undergo at least one cross-sex medical procedure or treatment regimen. So again, the central feature is that marked incongruence, so that distress that is causing the patient because of the difference between the gender that they feel that they are and the gender or the sex that they have been assigned. Again, this preoccupation with their wishes can cause isolation, relationship problems, difficulty at work, discrimination, and victimization. In adolescents, the male to female ratio is actually closer to 1:1, and persistence into adulthood is actually much higher than in children. They also have increased rates of mental disorder comorbidities, most commonly anxiety and depression, and they also have an increased risk of the suicidal ideation, attempts, and successful suicides. In terms of when it's diagnosed, when the patient or individual has a disorder of sexual development like CAH, more commonly there's gender atypical behavior and not necessarily a progression to gender dysphoria. So gender uncertainty is much more common in this population of people and varies as a function of the severity of the disorder. And in 46XY males, they have not found in their research that any endogenous systemic endocrine abnormalities in the sex hormone levels. But however, in females 46XX, they have found increased androgen levels. However, they are far below normal male levels. So if you're diagnosing these patients, or if a medical professional is diagnosing these patients, you have to think about different things that could potentially be their diagnosis, not necessarily gender dysphoria. So there's also nonconformity to gender roles, again, kind of rebelling or not doing what society says that they should act based on their gender. There's also transvestic disorder, which usually occurs in males. Their cross-dressing behavior leads to sexual excitement, which then causes distress, but it doesn't, there's not distress on their primary gender. It's more the excitement from the cross-dressing. And then there's body dysmorphic disorder. So the individual essentially just feels that a certain body part or body parts are not right or abnormally formed, and they want them to be gone. And that has nothing to do with their gender. And then in schizophrenia and other psychotic disorders, you can actually have delusions where you feel that you are another gender. However, this has to occur during a psychotic break or a psychotic episode, and then is not there in the absence of other times. So treatment of transgender patients initially begins with the diagnostic assessment of the gender dysphoria by a mental health professional, so someone who's trained needs to be making the diagnoses, consisting of psychotherapy and counseling. They actually say that you don't have to have it in order to begin hormone treatment or sexual reassignment surgery. They just really recommend it to individuals. Real life experience, so essentially is where the person completely emulates or becomes that other gender that they want to be in their day-to-day life. And hormonal therapy, the goal of that is essentially to suppress endogenous hormones and then maintain normal sex hormone levels for the person's desired gender. There's not very much research on this because it's a newer area. There's not a lot of evidence-based medicine and controlled trials which show which regimen is superior to another in the hormonal therapies. The ones that I put on here are from a large society, the Endocrine Society. That's their guidelines. And then also the World Professional Association for Transgender Health. They come out with the standards of care, which I also got regimens from. And then surgical treatment. Right now, they don't recommend that children undergo any kind of hormonal therapy or treatment until at least 15 or 16 years old, and or surgical treatment. And that they want you to wait until 18 years old to do that. So talking about treatment a little more, so there's Chaz Bono before treatment and after. Essentially, the baseline assessment, you want to take a good history and physical. So in your history, you want to focus on areas of their sexual health. Do they have history of sexual assault or violence, sex work, STIs? Asking about their psychosocial history. Do they have any other mental diagnoses? Family history, and just their overall general health. On physical exam, looking at height, weight, BMI, blood pressure, and then assessing secondary sexual characteristics. And then you want to get a bunch of baseline lab work, CBC, CMP, glucose, hemoglobin A1C if they're diabetic, lipid profile. Then you want to get FSH, LH, testosterone, estradiol, prolactin levels, and then Hep B, Hep C, HIV, a karyotype, a bone mineral density if they have osteoporosis risk factors, and an ECG if they have cardiovascular risk factors. Prior to starting any kind of hormonal therapy, it is very important for providers to discuss effects of hormonal therapy and to have patients sign a consent prior to initiation. So treatment for adolescents, there are several different types: fully reversible, partially reversible, or irreversible. So in terms of the fully reversible, there are no permanent changes to the body. They recommend that the adolescent has at least reached a Tanner stage 2, have persistent and lasting gender dysphoria or gender nonconformity, and the gender dysphoria worsened or presented at the time of puberty. And then any medical or psychological conditions interfering with treatment need to be addressed, and that the patient or their guardian, if they're not able to give informed consent, have given that. So thinking back to the hypothalamic pituitary gonadal axis, which we all love, we know that GnRH is released from the hypothalamus in a pulsatile fashion, which then stimulates the anterior pituitary to release LH and FSH, and then that stimulates the sex hormone production, androgens, progesterones, estrogens, depending on what sex you are. So essentially giving a continuous dose of the GnRH analogs will cause a suppression of that entire axis. And they also use medroxyprogesterone to decrease androgen secretions, and also spironolactone, again, to decrease androgen secretions. And that works by inhibiting adrenal androgen production and inhibiting androgen receptors. And then they also use oral contraceptives to suppress ovulation and menses in females. So partially reversible therapies, which can potentially cause long-term effects on the patient's biological development. You want to gradually increase the doses of these every 6 months to decrease the side effects. And at this point, they encourage the patient to fully assimilate into their desired gender. For females to males, you want they use testosterone in order to deepen the voice, which is irreversible. And the regimen there, testosterone 25 milligrams IM Q2 weeks, and increase by 25 until you get to the adult dose. Male to females, estrogens to induce gynecomastia, which actually can be reversible, and they use an oral 17-beta estradiol for that. And then irreversible are the surgical treatments, and again, they don't recommend those until at least 18 years old. And follow-up testing, it's very important for these patients while they're getting hormonal therapy to follow up with their providers. They want to do laboratory testing every 3 months during that first year, especially FSH and LH, and then estradiol or testosterone, depending. And then annual blood work, you want to look at liver function, renal function, CBC, random glucose, hemoglobin A1C. And then for those who use GnRH therapy, DEXA or BMD scans. And then again, physical exam, height, weight, blood pressure, routine physical exams. So treatment for adults, hormonal treatment, results in partially to fully irreversible inhibition of the gonadal axon if the patient stays on these long term, which is different from treating adolescents. The aim is to eliminate the characteristics of their natal sex and acquire the characteristics of their desired sex. So in females to males or trans men, the goal is to achieve the testosterone levels of a normal or natal male, which results in increased muscle mass, decreased fat mass. You have the increased facial hair, acne, male pattern baldness. You will have increased libido, clitoromegaly, decreased fertility, testosterone deepening of the voice, cessation of menses, and vaginal atrophy. And you want to reassure these patients when they start undergoing therapy that this isn't something that happens overnight. It does take time. Typically, you see some results within the first 3 to 6 months of treatment. However, maximum effects can be seen up to 5 years after starting hormonal treatment. Absolute contraindications for testosterone is pregnancy, unstable coronary artery disease, untreated polycythemia of hematocrits greater than 55%, and any kind of testosterone-sensitive cancer. And the regimens aren't necessarily as, I don't necessarily want you to remember the numbers or anything, but just know that there are different routes of testosterone that can be given, transdermal, parenteral, and then sometimes they use progesterones early in the hormonal therapy in order to assist with cessation of menses, and they can also use GnRH agonists for that as well. You can also use topical testosterone, which can be applied directly to the clitoris for enhanced clitoromegaly, but patients need to be aware that it may worsen their male pattern baldness. So for male to female trans women, sorry that's really small, a combination of estrogen and anti-androgens are used. Essentially, again, the goal to achieve the estrogen levels in normal females throughout their lives, so childbearing years, premenopausal, postmenopausal. Effects of estrogen therapy and anti-androgen therapy: decreased libido, decreased muscle mass, the redistribution of the body fat to more feminine apple kind of shape, softening of the skin, breast growth, decreased testicular volume, and again, maximum effects can take up to 2 to 3 years after beginning treatment, so reassurance that it won't happen overnight for these patients is important. Contraindications to this therapy: history of a venous thromboembolism, any estrogen-sensitive cancers is an absolute contraindication, and end-stage chronic liver disease is a contraindication. Again, the numbers aren't necessarily important to remember, but just knowing that there are different forms. Most of the things that I read, they kind of shy away from the oral estradiol treatments just because of increased risk of the venous thromboembolism, and also the increased avoidance of the first pass metabolism by the liver, and for non-oral forms is why those are preferred. And then obviously after you have removal of the testes, you can decrease the amount of estrogen that you can give, which also decreases the risk of thromboembolism. And then in the anti-androgens, they essentially decrease the testosterone level or the activity of testosterone, which thus decreases the need for the higher levels of estrogen, which also aids with decreasing thromboembolism risk and side effects. Spironolactone directly inhibits this testosterone secretion and androgen binding to the receptor. There also is a risk of hyperkalemia with that, so you need to watch potassium levels. The cyproterone acetate is not actually available in the U.S., but it's a progestational compound that has the anti-androgen properties. And then again, GnRH agonists and 5-alpha reductase inhibitors to inhibit the conversion of testosterone to its more active form. And then progesterone's not used as often. Some people have found that there is a positive effect on libido, but there's also a risk of weight gain and depression with these, and those are the different forms that I've found. And this is more, God, you can't really read that, can you? More for the residents, so I have a handout thing for the residents that I'll send out via email, and this just pretty much condenses the effects that you'll see with feminizing hormones, so the estrogens and anti-androgens, and how long it will take for the desired effects to come on and up to their lasting, when you'll see the maximum effect. And again, the same thing for the testosterone therapy. It's a horrible picture. So follow-up for adults. Again, same laboratory testing every 3 months as with adolescents for the first year, and then you can space it out to 1 to 2 times per year after. You want to make sure that these patients are following their routine cancer screenings. So any trans men who still have a uterus or cervix and breasts, you want to make sure that they are getting their pap smears per our screening guidelines and also undergoing mammograms per the screening guidelines. So that's very important to stress to your patients. And then there's some debate, male to females on hormone therapy, that there is a theoretical inconclusive risk of breast cancer. So they actually, several of the clinics' websites that I looked at, their regimens, they actually do start screening these individuals with mammograms starting at 40 years old. And then bone mineral density screening if you have risk factors for a fracture. So any prolonged hypogonadism, so you have a gonadectomy and then you don't take your replacement hormones, either way puts you at risk. Glucocorticoid use and previous history of fracture or family history. So risks of cross-sex hormonal treatment. For males to females on estrogen therapy, again, the increased risk of a thromboembolic event, which actually studies haven't shown is as high as they previously thought, but they do recommend stopping their estrogen therapy several weeks prior to surgery to decrease the risk, and that has shown to be effective. Again, inconclusive risk of breast cancer, liver dysfunction, coronary artery disease, severe migraine headaches, and hyperprolactinemia, which is rare. And for female to males on testosterone therapy, you can have a transient elevation in the LFTs. And then these breast cancer and uterine cancer, again, are inconclusive and not enough support has been shown, but they are theoretical risks. Especially with the uterine cancer, testosterone can be converted to estrogen. So we all know that unopposed estrogen therapies put you at an increased risk for endometrial cancer. And then erythrocytosis is also a risk. And then for both females to males and males to females, it's important before you start any type of hormonal therapy to discuss with them their future fertility. Do they desire it? If so, they should probably do like egg freezing or sperm bank prior to initiating hormone therapy, because they haven't shown that if you stop testosterone, you definitely start ovulating, or discontinuing estrogen will recover spermatogenesis. And then again, this is a nice concise chart that I'll give to the residents. And you can't tell in here, but some of the things are in bold, and those are what they consider the clinically significant risks. So surgeries. Individuals treated with cross-sex hormone therapy are eligible for gender reassignment surgery when they meet these criteria. So at least 18 years old and have undergone hormonal therapy continuously for at least 12 months, had a successful continuous social transition for at least 12 months, so that's that real-life experience that I mentioned earlier, compliance with clinic follow-up and treatment regimens, and then they have shown knowledge of all practical aspects of the surgery. And again, stopping the estrogen therapy 2 weeks before surgery and restarting it 3 weeks after has shown a decrease in the risk of thromboembolism. So here are some examples of the male to female surgeries. So obviously a bilateral testicular removal, a penectomy, vaginoplasty, clitoroplasty, vulvoplasty, augmentation, mammoplasty. They can get facial feminization surgeries, voice surgeries, and also have the thyroid cartilage or the Adam's apple shaved down. They do recommend that you wait 2 or more years after starting the estrogen therapy before undergoing any cosmetic procedures. And then the females to males, obviously hysterectomy, bilateral salpingo-oophorectomy, vaginectomy, bilateral mastectomy. The phalloplasty or the metoidoplasty, not as commonly undergone because it can be very disfiguring just based on the amount of tissue that they have to take. But the metoidoplasty, essentially the hypertrophied clitoris is stretched down, separated from the labia, and then the scrotum is constructed from the labia majora. And then they can actually get testicular prosthesis implants put into their new scrotum, which allows the patient to stand while they urinate. And then they can also get pectoral implants, liposuction, etc. So things that you want to be aware of after they get surgery: for the male to female or trans females, increased risk of urinary tract infections due to shortening of the urethra. They can also have overactive bladder and stress urinary incontinence following these procedures. And they're also advised to use vaginal dilators or regular penetrative intercourse regularly to maintain the vaginal width and their depth. Pap smears of the neovagina that has been reconstructed are not indicated, but you should perform periodic visual inspection with the speculum just to make sure you don't see any lesions or erosions or anything. And then for STI screening, it's important to do the culture swab and not a PCR. And then if they use the colon graft for creating the vagina, you actually need to screen that segment for cancer. And then in females to males, the phalloplasty, again, metoidoplasty, not as common. However, testosterone therapy use can lead to vaginal atrophy and then associated symptoms with that: itching, burning, etc. So some barriers of treatment to these individuals: again, the social stigma, fear of family rejection, and fear of how they will be accepted among their peers and others. Fear of confidentiality breaches in their medical record, and then access to healthcare providers who are trained in transgender care, citing a study that said about half of transgender patients said that they had to teach their doctor about transgender care. So that's an area that definitely needs improvement. And then expense, insurances, coverage and expense. That website link there is just a resource for different insurances that will cover some aspects of treatment. And I went to that website, and then I saw United Healthcare was one. I thought, oh, well, we have United Healthcare, so let's see what they offer for these people. So they have what they call gender identity disorder or gender dysphoria treatment. And essentially, psychotherapy will be covered if you have mental health services coverage on your plan. And continuous hormone replacement therapy, only the injectable, if it's done by the physician's office, will be covered under the medical plan, but then they may have coverage under the prescription plan, depending on what that is. And then laboratory testing to monitor the hormone replacement therapy is covered. Exclusions: any type of surgery is not covered. Any treatments received outside of the United States are not covered, and treatment of adolescents, the suppression therapy, is not covered. And then Medicare coverage, they actually cover some things. So preventative care, mammograms, pelvic and prostate exams, regardless of gender markers. So gender markers are essentially in insurance, whether you're marked male or female on your insurance plan. So a lot of these individuals are the other opposite gender, or they've applied. And so, you do a pap smear on a trans male, and it says, oh, a male got a pap smear, not paying for that. So there's actually a code now that will cover that, and then if it's denied, you just have to go back and get that covered, because it's supposed to be covered for those individuals. And then they cover any medically necessary hormone therapy as part of the Medicare Part D prescription drug plan. And then actually recently, May 2014, they started covering medically necessary sexual reassignment surgery. Prior to that time, they felt that it was, or what I read, it felt that it was more experimental surgery, but now they see it as medically necessary, so they've started to cover that. And then this was the Time magazine cover in June of 2014, just reiterating that transgender is an important issue that needs to have better education and more attention brought to it. So all these advocates for it are bringing national and international attention to this important topic. And we all need to learn more about it. And that's all. Questions? That's not my computer.
So in the follow-up for a female to male, I think that was one of the questions that was being asked.
Yeah, the testosterone. And it's interesting because I think it asked cancer. What cancer are you at an increased risk for, right?
I thought it was hormonal levels that you need to watch for, but.
Okay, I thought the question was cancer. Do you guys remember that question about the testosterone? I know.
No. That's the one that was stuck in my mind.
Yeah.
But that, so what?
And so they're showing the inconclusive if any, risk of cancer. So I think I think those questions are obviously all just a, hey, let's throw these out and see, you know, what everybody knows about it. And so just based on that, I can't say that the risks of the cancer are definitely there.
Well, I will say this, the 7th edition of the REI prologue does not have any questions on transgender or male, you know, even in terms of adolescence, it doesn't talk about that. I don't know, because it won't be until next year we find out whether the patient management in the office prologue will have any of there, but the newest REI does not.
Right.
So I don't disagree with your assessment of what the test questions were.
Yeah.
Did you see anything about intersex identifying persons?
In terms of?
Intersex persons don't have a gender identity.
Right, and I didn't really touch on that just because in ours I wanted to focus more on the transgender issues. But yeah, in terms of the definitions, a very important thing that I read over and over on the websites were that you can't restrict into two identities. There's multiple ones. So yeah, I didn't read in too much into the intersex stuff.
The other thing, going to gender dysphoria, it is indeed for sexual dysfunction, the concept of distress. If you have no concept of distress, it does not cause you psychological distress. It doesn't require counseling.
Right.
It's only when you, the patient, are in conflict / distress that requires you then to seek help elsewhere.
Right.
That's one of the things that goes for sexual dysfunction in any regard, anorgasmia, whatever.
Right.
If you're not in distress over it.
Right. Yeah, and they talked about different, you know, not necessarily every transgender person will go through the steps of, again, the counseling to the hormonal therapy to reassignment surgery. Sometimes they are just content in knowing that they are and acting, you know, being that person instead of having to go through the hormonal changes and things like that. So there are different categories, just depending on the individual.
When you talked about the cross-dressers developing sexual excitement and sexual arousal, and only if that causes distress would they need counseling.
Yep.
Well, thank you very much.
You're welcome.
Please hand in your evaluation.